So sometimes you put a slide deck together a little in advance. Judy asks, you know, and then things happen. And so last week I was actually at a meeting in Washington, D.C. with the National Academies of Science, Engineering, and Medicine, and it was all about the future of pharmacy practice and pharmacy education and innovation. And I will tell you, pharmacy technicians came up repeatedly, and the roles they play and how they can influence all of what we're going to talk about today. So if I get diverted and I start talking about that, you'll understand that that's the improv piece, right? I mean, I might just go a little, but I promise I'm looking at that clock. I'm going to get us back on time. I'm going to leave us plenty of time to ask some questions. And as you know, if you've seen me before, if you have a question, shout it out, right? If we get through 3 slides, but we have an incredible conversation, that's fine too. I'll leave the slides. All right? Yes, this way. There's a camera. Got it. Golly, now I'm, all right. I'll move back here, Judy. So, look, quick show of hands, just so I have a sense of the room. How many of you are from Colorado? Oh, not many. Okay. How many of you are from Nebraska? All right. Woohoo. Yeah, all right. Where else? Where else are we from? Florida. How many from Florida? Oh, geez. All right. Okay. North Carolina. I remember Raleigh-Durham. That was a great meeting. Where else? Washington State. Okay. Tennessee. I love Tennessee. Where in Tennessee? Oh, yeah. I like Memphis. I like Virginia, DC area, or Richmond, or okay. All right. All over. Who works in a community setting? Few of you. Who works in a hospital? More of you. Where else? Nuclear medicine, specialty pharmacy, at a college? No, sorry about that. I work at one of those too. Oof. You should get paid extra, but we don't. Okay, so a little sense of the room, where you're from, what you're doing. So some of this may apply more directly to some than to others. Certainly, as I think about the states represented here, I've actually been fortunate to speak and do a little work in a lot of your states, Florida, here, even a little bit in Virginia, occasionally in Nebraska when they let me, but not that often. Washington State, good friends there. So we'll try and work it in and try and make it a little bit about where you are too. Most of what we're going to talk about is probably on the community side, because that's where we see a lot of this movement. It's a little bit different on the hospital side or in the institutional side, because there's just a little bit clearer path for delegation of authority on some of these types of things. So the first thing, we always talk about, whenever you talk to pharmacists, they always talk about, we need to get away from the product. We need to move away from the product. We need to get away from dispensing so that we can do these these other services, whether that's immunizations or point of care testing or medication therapy management, whatever it is. And so it was really intriguing to me last week as I was sitting at this meeting in Washington, D.C., where a leader from the Community Pharmacy Enhanced Services Network said, stop. Stop saying that. 1, dispensing is what pays the bills. 2, dispensing is your best chance to interact with patients. Right? This idea of getting people to come in for other things. So and it's been in the back of my head for years, but I've never been able to think it as eloquently as he said it. And so it got me thinking, yes, we focused on dispensing, but there's a reason for that. And so again, this is where part of what I'm going to talk about today is I'm going to look up and say, I'm not sure I'm with it anymore. But what we've seen, right, and it's slow progress. I had dinner last night with some people and said, we've been talking about this for 40 years, about the role of the pharmacist, about growing, into a recognized provider, achieving provider status. And we'll talk a little bit about that. But really, it all comes down to expanding access to care. And that part I do agree with, 100%. That's my passion. So somebody mentioned health policy and pharmacoeconomics, right? I am not a pharmacist. I am the dean of the college, but my parents are both pharmacists. I worked in their pharmacy from the time I was old enough, and it's the impact that they had on patients. And if you've heard me talk before, you know I probably say this same thing every single year. And that's where I think pharmacy has an opportunity to continue to be the most accessible healthcare provider, location, et cetera. So we're going to talk about prescriptive authority. We're going to talk about what role pharmacy technicians play, because it is crucial. It is absolutely crucial about how we might get to a point where this is actually a business model. One of the other nice things that this gentleman said last week, that again, is always nice when somebody says something you agree with, is then you can go, yes, especially when other people in the room nod. We always talk clinical, and that's great. We're here for the patients. But even the founder and CEO of the Sisters of Mercy says, if there's no margin, there's no mission, right? If you can't make money doing it, you go out of business, right? You cannot stay in business. And so, we have to find a sustainable business model that allows all of these services to happen. And then we'll talk about the future. And why does this matter? And again, if you remember nothing else, and you likely won't because you just had lunch and your eyes are starting to close, and that's fine too. We can lower the blinds. We can use this as rest time. That's okay, right? This is about improving patient access to care. This is not about scope creep. This is not about pharmacists or pharmacy technicians doing somebody else's job. This is not about, right? This is about how do we provide care to patients where they are. And again, we spend a lot of money on healthcare in this country. I don't know if you know that. We spend a lot of money on healthcare in this country. And we don't always spend it wisely, right? We don't always get the best outcomes for the money we spend. So how can we reduce healthcare costs while improving access, while improving quality? And I think that's, right? We lean into our resources. We lean into the people who are here to help provide that care. Now the role, right? Why do pharmacies exist? Why do pharmacists exist? Why do pharmacy technicians exist? It is to be the medication experts, the source of medications, to optimize medication therapies. You look at every other healthcare provider, right? Yes, right? Whether it's a physician or a nurse practitioner, right? They have their expertise. But when it comes to medication expertise, it resides in the pharmacy. And I'll show you a slide here in a second. This compounds, it becomes so much more important when we talk about underserved areas. And I don't care if you're talking about rural or you're talking about urban. There are the places where there are no providers, where there is no health care. What can we be doing to provide access to those communities? I always talk about, so you know what happens when a community loses its pharmacy? Pretty soon it probably loses its grocery store and its high school, and then all of a sudden there's not much of a community there. And think about it, right? You can't age in that community if you don't have access to healthcare. So how do we begin to address that? So if you look at this map and you look at the places that are in the darker green, and gray just means they don't have data. But if you look at, these are places where we have shortages of pharmacy, which is basically to say everywhere, right? Maybe if you live in Pennsylvania, perhaps not. Anybody here from Pennsylvania, you can put your head down and rest. The rest of you, please pay attention for a little bit, right? We have shortages. One of the first people who spoke at this meeting in Washington, D.C. last week put up a slide and said there are 150 counties in the United States that do not have a pharmacy or a pharmacist. And everybody was like, whoa, that's incredible. 150 counties across the 50 states. In other words, about 3 per state. I flew today, but if I had driven, if I had driven today, right, that nice, you get to see a lot of God's country if you make that drive. For those of you from Florida or Washington State, if you ever have the opportunity. But guess what? You'll pass by. You'll pass by about 20 of those counties. So they talk about 150 counties without pharmacies. We have 25 of them in Nebraska. And if you look at where that line, that's I-80 until it dips down. But pretty much everywhere north of that, there are no pharmacies. So it's personal for me in Nebraska. My job at the University of Nebraska is to serve the healthcare needs of the state of Nebraska. And so when I start thinking about this, I start thinking about, and guess what? Other places that are impacted? Yeah, not Denver, but parts of Colorado for sure. Rural parts of Florida, Washington State, Tennessee. Again, maybe not in Memphis, but if my wife and I got married in Chattanooga. Between Memphis and Chattanooga, I guarantee there are places where we are underserved. And so there's opportunity. And so, when there's not a pharmacy, that means there's also probably not a prescriber. That means there's probably not a primary care physician or a nurse practitioner or a PA. And so how do we give people access? And again, I'm not saying specialty care. I'm not saying, transplant surgery, but how do we give them access to some minor healthcare needs? Again, so that the person who put that slide up said, and when a pharmacy closes, sometimes people have to drive 28 miles to get to a pharmacy. Is anybody from Nebraska? Right? There are people whose driveway is 28 miles in Nebraska. That is not, like we are talking at a different level, all right? We would love if there was a pharmacy within 28 miles of everybody in Nebraska. We're talking 100 miles. And so how can we begin to provide access to those people? And guess what? If we can do it in the rural or then we can do it in the urban cores. We can do it everywhere. And then we can start shifting resources and make better use of those resources as we provide care. And so I may have actually put this slide up in the past. I love this slide, but this gives us an idea because here, you know what the great thing about the United States is? Particularly when it comes to the practice of pharmacy or medicine. If you don't like the laws in the state you live in, move. And guess what? And you can move, and I live in Omaha, Nebraska. You can literally move 10 miles and have a whole new set of laws, a whole new set of regulations. And so that, at this meeting I was at, in every pharmacy meeting I go to, they'd love to throw up maps. I actually saw a map on the last gentleman's slides. I've already put up a map. We'd love to put up maps and say where pharmacy can do this. So there's always different colors and different shades. And then I was thinking, where they put, when medicine does a map, they're like, here's a quick map of all the states where a physician can prescribe for influenza. And it's just one color. It's just the map. And yet in pharmacy, we've made it so that we've got different colors, we've got different rules, we've got different ways to do this. And so there's a continuum. If we get way over here to this unrestricted, that's independent prescriptive authority. That's the ability to see a patient, to diagnose them, and determine the best course of therapy independently. There are some places where pharmacists are able to do that within certain categories because that's what they've been trained to do and their state allows it. Then there are states, and I will say, so for those of you from Colorado, you have some categories where pharmacists can do that. You also have some categories where you have statewide protocols. So hormonal contraceptives, smoking cessation, pre-exposure prophylaxis for HIV, so PrEP services, right? They have a statewide protocol, which basically says pharmacy, pharmacist, if you have the education and training and agree to follow this protocol, you can provide care for these patients. So if a patient comes in and, a female patient comes in and needs contraception, right? There is an algorithm you walk through and you're able to provide them that care. It makes sense, right? Follow the instructions. Now, again, not diagnosing brain cancer, not doing surgeries, but for common ailments, again, for those of you who work in a community pharmacy, has anybody ever come in and showed you their rash? Yeah, rash. Has anybody ever not come in, right? I mean, and I'm hoping it was only in PG and G-rated places. So this idea that people are not coming into their pharmacy and asking, or, hey, does this look like pink eye? Yes, it does. Please stay away. It's happening in pharmacies. So, I mean, the need is there. So on the left side of the screen are restrictive, but still opportunities for pharmacists to be involved in prescribing. These collaborative prescribing opportunities. In the most restrictive states, it's a patient-specific collaborative practice agreement. What does that mean? It means if the patient has an existing relationship with the physician, with the prescriber, and then comes to the pharmacy, the pharmacist can act on that. Well, that's great. Again, if you live in a very rural community and there's one physician and one pharmacy, right? Or you're talking about specialty care, or in an ambulatory clinic or in a hospital setting, that makes a lot of sense. It falls apart, though, when we talk about something like Group A strep or influenza, where most of the people who are coming to the pharmacy are coming because they don't have an existing primary care provider. They don't have an existing relationship. So that's where we move into population collaborative practice agreements, or CPAs, where a patient who has the signs and symptoms of the disease can come into the pharmacy, and the pharmacy will do an evaluation, and if they meet the criteria specified in the collaborative practice agreement, they are able to provide care, to dispense a medication, regardless of whether or not that patient has ever gone to Dr. Smith's office or even knows who Dr. Smith is. So again, what that does allow the pharmacist to provide care to the community, but you have to find a physician willing to countersign that, willing to delegate that authority. And therein lies the barrier, right? If we can get to the far right side, to that unrestricted, well, then any pharmacist with the training, the expertise, can provide that care. So backing up a little bit, these CPAs, these collaborative practice agreements, formal agreements, right? These are signed contracts, if you will, with very well-defined scopes. This group of patients with these signs and symptoms, maybe during this period of time, with this test run, with this physical assessment done, then the pharmacist can make a determination. It requires a lot of collaboration and communication, which, oh, by the way, is what we should be doing in healthcare, right? We should be talking to each other, the pharmacist and the physician. But guess what? You know what nobody gets paid to do? Talk to each other. I mean, that is the shame of the system we've designed, right? That is a cost to the provider. It is not a reimbursable event. Despite that, we see these, and they're not new, right? We've had these for 30 years in different states. And again, we see them all the time in clinics, in hospitals, in the VA system, particularly for things where it involves the adjustment of a medication. So think about a patient with diabetes in adjusting the insulin, right? The pharmacist or the pharmacy, you guys you can get the blood sugar, you can get the glucose, right? You can get an A1C and adjust the therapy accordingly in the pharmacy. That happens, right? The pharmacists, they do that all the time. Similarly, hypertension. Anticoagulation is probably one of the most common, right? And why? Because again, it's a fair bit of work for things like warfarin, and the physicians are just happy to have somebody else do it, right? And so that, you see opportunities there. So what are the benefits? And again, let's keep the most important person as the most important person here. This is patient friendly. This improves patient outcomes. One of the other things, and I loved it, even though I'm an academic, right? I do research. That's my job. And somebody said, we don't need any more pilot tests. We don't need another study that says the pharmacist, the pharmacy has a positive impact on outcomes. We've done those, right? That's, for those of you from North Carolina, the Asheville Project from 30 plus years ago clearly demonstrated the value of incorporating the pharmacy into the healthcare team. And yet we feel we need to reinvent that wheel repeatedly and show it every single time. And I think we're beyond that now. We should be beyond that, right? We should be saying it is clear that when the pharmacist and the pharmacy is involved, care improves. Outcomes improve. And when outcomes improve, generally that means costs are better controlled because people are not getting sicker and utilizing more care. What an amazing idea. When the pharmacist talks to the patient and shares that information with the prescriber, they have a better idea. Now, we've gotten better with electronic medical records and the ability, to track fills, but how many patients in the history of ever do you think have told their physician that they're not taking their medication as directed? Somewhere between 0 and just a little above, right? But if we can provide real facts and real information and improve that communication, again, better outcomes for the patient. And we improve efficiency. Everything goes a little bit better. But they require individual agreements. They require people working together. They require somebody giving up a little bit. Maybe giving up a little bit of their scope and worrying about who's coming to take their job. There's a burden, right? We love talking about adding things in the pharmacy, don't we? Hey, we should start doing this. It's a little bit, and I'm looking at you, it's a little bit like our curriculum at the College of Pharmacy. Every year somebody says, we should teach this. We should add a class about this. Okay, great. What are we going to take away? Well, nothing. Everything is so important. Well, so we just jam more into the same 10-pound bag, right? And it's the same in the pharmacy. We're always saying, oh, what if we do immunizations? What if we start doing testing and medication therapy management and, technician, maybe you could do this and this and this. Well, you probably still work the same number of hours. You probably don't get paid anything more, right? So there is a burden, and we shouldn't pretend there's not, right? We shouldn't pretend that we can continue to add things on. Now, that said, we also shouldn't be afraid to do it. We should be thinking about, okay, how do we offload those things that we no longer need to be spending our time and effort on, right? Is that technology? Is that artificial intelligence, right? Is there an algorithm? Are there things that we could be, we see it in pharmacy today, right? If you call in to get a refill on your prescription and you call one of the big chains, are you going to talk to a person? No, not even, right? Now, is there good and bad to all of it? Yes, of course there is, but there is a work towards efficiency. Finally, right, this is pharmacy This is the pharmacy approach to scope expansion. It's very much a mother may I, right? We seek permission. So of your states, can pharmacists and pharmacy technicians do immunizations? Probably, but yeah, I think at this point, everywhere. Can they do it for all ages? No? Are you in Florida? Virginia? Okay. I know it's the case in Florida, right? But I happen to help write the Florida immunization training program, and every couple of years they come back to us and say, great news, now we can go down to 7 years old. And so we write another training program, they send me more money, I love it. Or, or this year we've added, now we can do COVID vaccination. Great, or we write another one, right? Send them a bill. It really is fantastic for me, it keeps me in business. It's really pretty crappy for patients that we incrementally ask. And because collaborative practices by nature, these agreements are narrow. And so, yes, great, the pharmacy is doing influenza testing and treatment, and then there's a pandemic, and all of a sudden COVID comes along. Well, now, maybe the government intervenes. Otherwise, you've got to go back and get another collaborative practice agreement, basically to do what you've already demonstrated you can do. So that's where statewide protocols come in, right? It's really saying, wait, here are things we, as the state of Colorado or the state of Nebraska, agree pharmacists are trained to do. And if they agree to follow standard practice, we're going to allow them to do that. Now, again, every one of these has to go through whatever your board process is to get approved, but it allows for something closer to independent prescribing, right? We can expand and roll them out much more quickly, right? The Colorado Board of Pharmacy or whoever is the legislative unit here in this could say, oh, Lyme disease, it's the new issue here. Boom, pharmacists, you can handle this. And like that, we can roll it out. Now, people will have to be trained, there will have to be programs, all of those other things, right? And so that's why you see so many of these linked to public health, right? To infectious disease outbreaks and things of that nature. So we see a lot of it, right? A lot of what goes on with immunizations now is under protocol. You see it with naloxone. You see it with the contraceptives, tobacco cessation. Generally things where there's not a diagnosis necessary. That's easy, right? I think there's generally we say, oh, okay, that makes more sense. Great in those rural communities where there is nobody to enter into a collaborative practice agreement. And again, that idea of being timely. But now we have to have a trained workforce, right? A group of people who know what they are doing, who are and can demonstrate competency. So, I teach at the University of Nebraska. I feel like we do a pretty good job. I'm here in the University of Colorado. I feel like they probably do a pretty good job. But do I know that every school, that at every state is meeting? That's a leap of faith for a state board of pharmacy. So now all of a sudden we get into competency and we get into additional training and credentialing and privileging and all of these other things, and which we'll talk about a little bit too when we talk about billing and the role that technicians can play. On the far end, and we're just starting to see it, is you're trained to do this. Go do it. You don't have to ask us. And that's not the right. Again, that's not the model pharmacy generally operates under. It's much more. If I had a nickel for every time a pharmacist in some state came to me and said, "Don, where in our board regulations does it say that pharmacists can test for Group A strep?" I'd have $1 million and I would have never probably found it. 10 years ago when people first started asking me. By the way, here's my challenge. If you've got nothing but fun and free time this evening, if you're right, you're like, I go to every state's medical licensing and see where it specifically says physicians can provide immunizations. If you can find a single state where it definitively says in the Medical Practice Act that a physician can provide immunizations, I will buy you your next Subway sandwich. Cut it and paste it, send it to Judy. I will find you. Right? Because it doesn't. Right? It doesn't have to. It says physicians can do what they are trained to do. And that's where we need to get with pharmacy. So we're beginning to see it for some minor ailments, for allergies, for some skin conditions. And again, that's really the best case. So this is great. And again, in a setting tied with and in conjunction with dispensing, because guess what? The dispensing is what generates the foot traffic. It's what gets people into the pharmacy. It's what allows you to do other services like this in your pharmacy setting, but only if you have a team. Only if you have the right people and the right support. And that is, and this is, again, for those of you who have heard me in years past, this is where I come back and say, that's where you need a skilled pharmacy technician. You need a group of people working together, understanding their roles, and just like pharmacists are also, why don't the physicians allow us to do this? And then I always think, well, look the other direction, and why won't you let your qualified pharmacy technicians do certain things? And we need to get beyond that. We need to be working together and allow people to do what they're trained and capable of doing. Because again, remember, health economists, the only way it works is if it makes money. And the only way it makes money is if we keep the costs as low as possible. And the best way we keep the cost low as possible is if we don't have that pharmacist, the most expensive person in the building, doing things that are not generating revenue. And so, right, patient intake, talking to the patient, making sure they are a candidate for the service. The medication reconciliation, right, getting the information, helping with the prior authorization, right? Certainly we know that's role that pharmacy technicians can be playing and should be playing and have been playing and will continue to play. But we need to get the pharmacists out of the way. And then let's elevate. Moving beyond all of these things. So that means investing. And so the fact that you're here is a little bit of me preaching to the choir. Right? You are interested in your advancement. You are interested in taking that next step, learning more, seeing what else is out there, pushing yourself, pushing others. So I appreciate that. Yeah, absolutely. Thanks. Okay.
My biggest struggle is going to our labor resource community to kind of justify the role. We have to, as far as financial, budget role. So I understand, like you mentioned, having pharmacists do these roles that technicians could really do, and they get a lot of money, they should be doing that. But how would you say we combat that part? The part where if we do create these advanced roles, how do we make sure that they're equitable in a sense from their compensation, but also getting past a lot of things?
Yeah. So Quinn, if I knew the answer to that question, I wouldn't be here, right? I'd be on my yacht somewhere, right? I mean, it's the $1 million question, right? But I will tell you, it's the exact same question the pharmacists were asking last week. We would love to be doing this, but we need to get provider status, or we need to get the health system to sign off and allow us to do this. And at some point, and I hope not, but someday the reckoning is going to come, and that that pot of gold that is 340B pricing is going to be, and then all of a sudden people are going to be like, oh yeah, no, yeah, technician doing that. That sounds like a great idea. Yeah. I mean, that's honestly, I hope, again, I hope it doesn't get there. I hope we can be more proactive. I hope we can demonstrate value. Again, I don't want to do 100 more pilot tests to say this. We just need to get people in the room thinking. Don't worry about how it's been for the last 20 years. How would you do it if we were designing it today? And that's where, and let's bring in people from outside of healthcare. You bring in a systems engineer, first of all, they'd run out of the room crying in about 3 minutes, but pretty quickly they would say, oh my gosh, this is so inefficient. We need to do this. So keep fighting the good fight. That's where all this gray comes from, right? So, but you just have to keep pushing, and you have to keep advocating. And I think that probably is about my last slide, is advocacy. You've got to continue, and build that network of people who get it. And anytime there is an opportunity presented, well, who could be doing this? We could, right, and show it, and then actually do it and do it well, and all of those things. And so again, all of this, but to the point, this would be easy, right? We'd all be doing this if the money was there. And it was interesting. So, in this pharmacy meeting last week, and everybody is talking about how do we get provider status so that pharmacists can begin to bill fee for service. And there were 2 primary care physicians in the audience. And finally, one of them just couldn't take it anymore. And he got up and he said, we don't make any money billing fee for service. We are actively looking for alternate methods, right? We have our reimbursement is getting squeezed. We make money on procedures. We make money on value-based contracting. And so we in pharmacy need to be thinking, we don't need to be running into the room where everybody's trying to get out of. We need to get to the room, right, that they're trying to get into. And so the conversation becomes, and Quentin, I think this is ultimately where the story is, how does this impact the payer, right? How do we begin to take on some of that risk? Because that's really where the money is, right? Where we say, if pharmacy technicians are doing this, you're going to see improved outcomes and lower cost. And we're willing to put our money where our mouths are a little bit, right? So, and it was a great line that fee for service helps you make payroll, but it is those value-based contracts that help you make margin, right? Or profit. And that's where we need to be thinking about. So, but for pharmacy today, it's still about even getting into that room. About just being, right? Even if your state allows you to do these services, how can you do them in a way that to a patient, it's comparable to everywhere else in the healthcare system? Isn't it? Who's heard me talk before? A few of you. I'm so sorry. I am so sorry. That one of the things that really grinds me is when patients go to the emergency room for things that they could be going to the pharmacy for. When you drive down the interstate and the emergency room says that it's 5-minute wait time, and you're like, perfect, I guess I'll go in. Well, that's not an emergency, right? That is an entirely terrible use of our resources. But why would a patient go to the emergency room and not the pharmacy? Because their insurance will pay for care in the emergency room and not in the pharmacy. Earlier I said if you take one thing away. If you take 2 things away, take that away. That's bad, right? And that's not just bad for pharmacy. That's bad for us as taxpayers, right? We are now paying $500 for somebody, to have their toe fungus looked at or whatever it is. We don't want to do that. So how do we begin navigating the current billing? And again, this is not in any way, shape, or form where I think we want to get to ultimately. but this is a pass-through step, right? This is a transition for pharmacy, right? Understanding the billing codes, understanding the process. How many of you, as part of your job, have ever been on the phone with an insurance company? How many of you love that part of your job? Keep your hands up. Okay. Thought I could trick somebody to keep that hand up for just a second. No, right? No, but yeah, right. Yeah. Yeah. Hey, could you put me back on hold? I was really into this. Yeah, no. But I will tell you, pharmacy billing is probably light years ahead of medical billing, right? In terms of efficiency and being able, right? And not in the coding and all of these things and all of this rigmarole that you have to do. I mean, you basically need like an engineering degree to figure out how to bill, which is, so if you think about most medical practices, most health systems, there are people in the basement who are doing this. Well, so how as a pharmacy do you begin to do that? There's an opportunity, right? There's an opportunity to build a skill set, which, by the way, if you master that, you would invite me to your yacht because right? You'll be able to write your own ticket. There are some other payment methods, particularly on the inpatient side or the clinic side, where maybe a pharmacist can bill through a physician incident to. So there's a lot of work, right? I checked minutes before I walked in here. Colorado is pushing for a provider status bill that would allow, I see heads nodding. I assume you're from Colorado, right? I mean, this number, what's that? Illinois. So actually, and at the national level, it's happening. And yeah, go ahead. They do have liability. Yeah. They will. That is one of the questions that always gets asked. Yes, but every time I've ever asked that question of an insurance company, particularly, again, if we're talking about some of these minor ailments, it's tens of dollars a month. It's not thousands of dollars, right? But yes, with more responsibility comes more liability, yes. So all of these things are happening. I love this idea. This is crazy. Anybody buy a cup of coffee this morning? A couple of you. Did anybody else pay for that for you? Or did anybody buy that themselves? I generally, right? I mean, everybody in this room paid for it. Yeah. There is something to be said in healthcare. Has anybody ever had a cold? Bought cough medicine? Bought, Sudafed or something? You just go in and you pay for it. But somehow, with almost everything else in healthcare, we've got it to this idea that, God forbid, I should spend any of my money. Right? I pay my health insurance premium. But there is a model out there where for minor ailments, for inexpensive things, and I get it, not for everybody, but there is a cash model out there. And I remiss if I don't mention it every time. Don't forget that. Don't forget those patients. But then it's really this value-based care, this idea of cost avoidance. And we've talked, that is in effect what medications do, right? You take your statin or your ACE inhibitor, why? Not because it necessarily makes you feel much, but it avoids downstream healthcare events. It keeps you out of the hospital. We always, now this was before medication prices went, right? But if you can keep somebody out of that hotel across the street, right, with all the people walking around in, nursing outfits, you can save quite a bit of money. And so, that's value-based care. And likewise, the things that happen in the pharmacy can be the same way. And so really, again, advocacy. So Quentin, back to what you said, and it takes, and this was the first time I'd ever sat in the room with APHA, ASHP, ACCP, other acronyms that have P in it, I promise you, and they all said, we're all on the same page here. Now, I I take it with a grain of salt because rarely are they ever on the same page. But that's what it takes. And it takes the AAPT and PTCB all coming together as well and saying, this is, yes, this is good for us, but more importantly, this is good for patients. And that's why, you know, that if you keep your eye on that prize, that's really how we get there. So need for recognition and reimbursement. And until something massive changes, right, it's going to be a state by state battle. It's going to be a slog in every single one of these states. And I will say, and Washington State right up here in front has had provider status and has had reimbursements for, a decade at least, maybe even more. And yet they still continue to have to battle every single day, right, to expand and move it even further. So it never stops. And while I don't think we need to have a whole lot more pilot programs, we need to be documenting. We need to be documenting when the technician is involved, what costs were avoided, what mistakes were avoided. Then that's how you can begin to go back and show an ROI. That's how you can go back and say, here's the positive impact. So get involved. Be an advocate. You are here. You're a leader amongst pharmacy technicians. Set up meetings, talk to people, push for this because it's the right thing to do. Never quit learning. When you see an opportunity, think of how you can, right? Don't run away from it, but say, how could we be involved with the understanding that we're going to have to give up something, right? We're going to have to shift something. We're not just going to take things on. And then, support each other. Support the advancement of the pharmacy technician. If I had a crystal ball, right, and I don't, again, I'd be on my yacht if I did, the role of the technician is going to do nothing but increase. If we look ahead 20 years, I bet the role of the technician looks an awful lot like what the Bachelor of Pharmacy looked like 30 years ago. And I for one, hope that is what happens. And so continue to push, continue to support each other. All right. I talked longer than I wanted to, but that's pretty normal, actually. But I think I have a few minutes for some questions. Yes.
One is a question of something I brought up with Colorado is the hope of expanding, moving the technicians into match that the designation as nurses, where we have a different level from a RN down to an LPN and all those. As maybe is that feasible or not really feasible?
It's outside of the box, so it won't be easy, but yes, it's feasible. Why? I mean, we treat today's laws as though they are somehow, brought down from the heavens, when in reality, it was somebody in a room at some point in time said, well, let's make this restriction, or let's limit somebody. Now, will you have to show the education, the training, right? Will there be more responsibility, more liability, all of those things? Yes. But I will tell you, one of the things I came out of that meeting last week thinking is, how do we begin to move technicians along without pulling people, where somebody was like, oh, well, great, we'll create a pathway and all these technicians can come to pharmacy school. And I said, great, we don't have enough pharmacy technicians today, and we're going to pull them all out of the workplace? That sounds like a dumb idea. And so how can we begin to, in place, elevating people, taking on more responsibility? Yes, I see at some point there is I don't know if it'll be 1 step, 2 steps, 8 steps, a gradation between an entry-level pharmacy technician and a PharmD with a residency and 3 board certifications. But sure. Yep. Bless you. Yeah, yep, absolutely. I love it. Yes.
Because people look at pharmacy as outpatient pharmacy, right?
Yeah.
Walgreens, Costco, Kroger, all that. That's pharmacy for everybody else. How do you get to a point? Pharmacy is more than that. We have so many opportunities, and you guys here in the room work in so many different areas that are behind the scenes that they don't understand it. But when you're like, oh, come into pharmacy, yeah, I don't want to work 10 hours a day and yell at my patients.
Yeah.
You have to be
Mhm.
more than that.
Yeah.
I think that's where the challenge is.
Yeah.
And so I'm one of the few pharmacists in the room, but I tell a lot of students, if you want to get into pharmacy, become a pharmacy tech first. Less expensive, try it. If you love it, then you
Yep.
can move forward and do other things. If you want to stay a tech, great, stay a tech, that's when you need it. There's a demand for that. But I think that's what the challenge is. How do you get people excited to get into this career? Can I answer that?
Yes, please. Yes. If you would. Yes, please.